Oh, yes, for you it does, but for us as viewers, it's correct left to right.
Okay.
Pete, what's a good email address to share this thing with you?
P. Lecor, P-L-E-C-O-U-R-S.
P-L-E-C-O-U-R-S.
O-U-R-S at Rillahan, R-I-L-L-A-H-A-N. And what I'll do is
.com or?
Yep, .com. And what we'll do here real quick, let me just so you get a feel for how the sharing works, Dr. Pierce. Once you're done with that, sending that, I'll just let me just give you a remote control of Dr. Dorsey's slides real quick here. What you'll see, hopefully, is a pop-up telling you you can take control right on top of the slide. If you click anywhere on the slide with your mouse, you will be in control. I'm just, right now, you have to kind of click on the slide. There it goes. Now you're in control. If you use your mouse, so do you notice a little delay there?
Yeah.
So
okay,
that's how it works. So
and
when you're I would take it back when you're done. When you say thank you very much, I would just abort your control.
Right. Perfect. This is good because this is what I assume this is what we're doing tomorrow as well, right?
Yes. Yep.
Super. Well, good. This will work great. Thank you.
Okay. No problem. And
do you want me to broadcast, Pete?
I got your yeah. Let me go ahead into loop. So what I would suggest then, so we don't have Dr. Bath yet, or Dr. Dorsey. Oh, we do have Dr. Dorsey. Great.
Yeah, Jonathan's logging on right now.
Okay. So what I will do at the top of the hour, I will just check with Maureen, Joanna, and Lynette just to make sure we're good to start at 7. And I will do the VOG introduction of Drs. Bath and Kabani. So you basically wait until you hear me say your names to turn your cameras on and unmute, and then you can take it away the rest of the night. Everyone else, if you could just keep your cameras off and your mics muted until it's your turn to present, that would be great. And so I will do the same. I will turn off my camera now. And whenever you are ready, I'll start the loop. Thank you.
Okay, hitting broadcast now.
Ladies and gentlemen, thank you for joining this VSIG virtual event. Our program will begin at 6 p.m. Central Time. We ask all attendees to please confirm that your Ring Central name is showing your actual first and last name. This will assist the program moderators during Q&A segments. Thank you, and our program will begin shortly. Ladies and gentlemen, thank you for joining this VSIG virtual event. Our program will begin in about 4 or 5 minutes. We ask that all attendees please just confirm now that your Ring Central name is showing your actual first and last name. This will assist the program moderators during Q&A segments. Thank you, and we'll begin shortly. Ladies and gentlemen, thank you for joining the VSIG virtual event. We ask all attendees now to please confirm that your actual Ring Central name is showing your actual first and last name. This will assist the program moderators during Q&A segments. We encourage you to submit your questions at any time by using the Q&A button at the bottom of your Ring Central screen. Do not use the chat box for questions, as we will not be monitoring the chat. And now, to begin the program, we welcome Dr. Loe Kabani from Henry Ford Hospital at Wayne State University, and Dr. Jonathan Bath from the University of Missouri School of Medicine. Doctors, the screen is yours.
Good evening, everybody, and thanks for joining us at VSIG Live. This is our first VSIG, hopefully many more to come in the future. I'm Louis Kabani. I'm the Program Director for Vascular Surgery at Henry Ford Hospital, Wayne State University. Jonathan, do you want to introduce yourself?
Sure. I'm also the Program Director at the University of Missouri, and we really appreciate you all joining us this evening.
Yeah. So just some housekeeping stuff before we introduce our first speaker. Just a reminder, please put your questions in the Q&A button at the bottom of your screen and submit any question at any time. We will go over the Q&As at the end of each session. Don't wait until the end of the presentation. Okay, let's get started. Our first presenter is Dr. Chelsea Dorsey. She is an assistant professor of surgery and director of preclinical advising at the University of Chicago Pritzker School of Medicine. Dr. Dorsey's presentation is titled, "What does a vascular surgeon do and why is it awesome?" Dr. Dorsey, take it away.
Great. Thanks so much for having me this evening. I'm excited to get things started for this VSIG Live event. Again, my name is Chelsea Dorsey. I'm a vascular surgeon at the University of Chicago. Sorry, just trying to move the screen. There we go. All right, I have no disclosures for this presentation. All right, so this is the money question, right? What is a vascular surgeon? So I like to sum this up by basically saying that we are the surgeons that work on all of the blood vessels in the body. So the arteries and the vein, pretty much everywhere except in the heart, and there's actually some exceptions there, and except in the brain. What this means is that we have an incredible amount of variety in our day. So we work on the legs, we work on the arms, the abdomen, the neck, pretty much everywhere in the body, which is great. We also work on the structures that all other surgeons are trying to avoid. If you think about it, whenever anyone else gets into any bleeding, we're the ones that they call. And it's kind of nice to be the supermen and superwomen that get to swoop in there and save the day. And we are often the calm voice in the room when everyone's kind of panicking. That last point there, we are not interventional cardiologists, we're not interventional radiologists, we're not cardiac surgeons. Those are all awesome specialties too, but there are some distinct differences in what we do as vascular surgeons. I think one of the main points that I want to get across is, and one of the reasons why I went into vascular surgery, is that we treat patients often from beginning to the end of their disease process. So for instance, with peripheral arterial disease, we often see patients who are asymptomatic with poor circulation, and we'll treat them medically. We'll also treat patients who have mild symptoms with minimally invasive techniques using endovascular stenting and angioplasty, which I'm sure we'll talk about at length throughout the session. Then when patients progress even further, we have a lot of open options, meaning surgery that we can offer them. And those patients who kind of get to the end stage of PAD, we also can offer amputations. None of the other specialists on that list can do that. So again, I think that's one of the awesome points of being a vascular surgeon. All right, so I touched on the first bullet point there, variety, for sure. Again, working all over the body. We do short, minimally invasive procedures that take half an hour. We do long 12-hour cases. So pretty much anything that you could think of, we do it. We also embrace innovation and technology, which I think you'll also see throughout my presentation and some of the other sessions this evening. That fourth bullet point there, this is really why I came to practice on the south side of Chicago. There are health disparities related to a lot of the vascular disease processes that we treat, and we have an opportunity to have an impact, especially with vulnerable populations. Also, demand is likely to remain high over the coming years as the populations continues to age. And as I'll also try to touch on at the end of my presentation, there are great opportunities for career development. Pretty much everyone on this call, on the panel, I bet wears a lot of different hats. And you can do a lot of things outside of the operating room as a vascular surgeon. And then I always like to put in the last point there, more and more women are entering the field, which is always a great thing. All right, so I'm going to try to do kind of a crash course to show you some of the disease processes that we treat as vascular surgeons. One of the first things you might think of is abdominal aortic aneurysms. So these are a ballooning or enlargement of the aorta. This is the abdominal aorta here. Obviously, the thing we worry about is it rupturing or leaking. We have many different ways to approach treatment for this problem. So we can put stents in, and we do this in about 80% of patients now. But we still do big open procedures as well, where we sew in grafts, which is shown here. We also treat patients with carotid stenosis. So if they have narrowings in the blood vessels that feed the brain, we can place stents or do open operations in order to decrease their likelihood of having a stroke in the future. As I mentioned before, we treat patients with peripheral arterial disease. This is a patient with kind of what we would call a ratty aorta. They have a significant amount of narrowings and obstruction, areas of obstruction in both the aorta and the iliac vessels. We can do angioplasty and stenting. We can do big open operations, and we can do bypass surgery on the legs. There's really a lot of creativity in what we do as vascular surgeons. This is my particular area of focus. We see patients with varicose veins and venous insufficiency, and there's people on the spectrum who come to my office specifically for cosmetic issues, but then there's patients also that have a lot of problems with venous stasis ulcerations as well that we treat. We also see patients with end-stage renal disease, and we are often the surgeons who create arterial venous fistulas for those patients, or so in AV grafts for those patients, and often we're also putting in temporary catheters so that those individuals can get dialysis. And we also treat patients who have DVTs or deep venous thrombosis. We often come into play when they need what's called an Ivc filter, which is pictured here. That's placed in the inferior vena cava, basically to prevent clot from traveling to the heart and lungs. This list of disease processes is not exhaustive, but I think gives you a good sense of again, the variety in the field, which is part of the reason why I love it. And I just wanted to put this in at the end as well. A lot of people ask, are you just in the operating room all day? And the answer is no. I do a lot of things outside of the operating room. So you can see here, this is us doing a radiofrequency ablation for someone with venous insufficiency in the clinic. I also do a lot of work, as I said, with medical students. This is us in a surgical simulation course that I started last year. This is me at the white coat ceremony with a bunch of the career advisors at the University of Chicago as we're welcoming the new class of medical students. And I also do a lot of work with diversity, equity, and inclusion in the Department of Surgery. So again, I just wanted to highlight that there's a lot of opportunities for career development and things outside of the operating room too. I personally love being a vascular surgeon, and I'm happy to talk with anyone after the presentation if you have any questions. Thanks.
Well, thank you very much, Chelsea. I think we'll move on at the present time. There's no questions that we see in the Q&A box, but we do encourage you to go ahead and put some questions in there. And when we finish up the panel, we'll go ahead and come back to that. So next up, we're going to hear from Dr. Joni Lugo. Thanks for joining us. I see you there on video. She's Chief of Surgery at the Vascular Surgery at Bellevue Hospital Center and works in NYU. She's an Assistant Professor of Surgery, and her presentation is entitled A Day in the Life of Vascular Surgery. Dr. Lugo, it's all yours.
Just
hey,
stand.
thank you. Thank you, Dr. Bath and Dr. Gabani, for having me and for inviting me to present tonight. My slides are moving without me touching them, just FYI, everybody. So I'm sorry if it's going a little bit ahead of time. Just to introduce myself, as Dr. Bath already said, I'm Joni Lugo. I'm an Assistant Professor of Surgery at NYU. Today is my birthday, and the reason I included that is just to demonstrate that, is day in the life of a surgeon. Can't always pick and choose when you do your celebrating. So I knew I had this presentation tonight, and so we did my birthday celebration last weekend, and I think that's just kind of part of being a surgeon in general, but also being a vascular surgeon, is you have to be able to compromise and kind of work around these special occasions. So I went to the University of Michigan for undergrad and for medical school. Did my general surgery training at Beth Israel Medical Center in New York City, which is now Mount Sinai Beth Israel, as many of you know. I did my fellowship at the University of South Florida in Tampa. And I started out as the Associate Program Director for the Vascular Surgery Integrated Program at Lenox Hill Hospital, and I spent 2 years as an attending there before joining the NYU practice and the NYU School of Medicine. So I'm currently as was stated, the chief of Bellevue in New York City, and just the chief of the Division of Vascular Surgery at Bellevue in New York City.
If you just click anywhere on the slide, you should get control now.
No, that didn't work.
Okay, you can just let me know next slide. I'll advance for you.
Okay, next slide. So in general, typical work week for me looks this way. Monday morning, we do Bain cases, generally 3 to 5 cases in the morning. In the afternoon, we have our clinic at Bellevue Hospital. Tuesday is an OR day for me. Wednesday is an OR day for me. Thursday, again, we have clinic in the morning, and then the afternoon is kind of an undesignated time for me. Generally when I have meetings with other physicians and people in the hospital, or with the vascular lab issues, things like that. And then Friday is another OR day for me. And the picture that I showed you here is just to keep you guys interested. This is a neuroendocrine tumor that was sitting on top of the aorta. And we did a joint case with surgical oncology to remove this. You can move to the next slide. So in a little more detail, 7 a.m. generally is when we start the morning with a conference. Just about every morning there's a conference or a meeting at 7 a.m. 7:30, generally I'm seeing the patient in the holding area and rolling the patient to the operating room. Given that we're in COVID times, most of our meetings are being held on Zoom, which I'm sure is the case with everyone. So I'm able to keep on the line, stay in the conference, generally on my phone as I'm rolling the patient back to the operating room. The residents are all expected to attend for the entire conference, so they generally are not present until the end. So by 7:45, I have the patient in the room. Generally around 8 or 8:15, the residents join from conference. While anesthesia is getting the patient put to sleep, we will run the list, see what's going on with the inpatients, and by 8:30, we're generally making a skin incision on the first case start. Depending on the case, as Dr. Dorsey mentioned, it could be 2 hours, it could be 10 hours. In this example I gave you, I'm thinking maybe like an AV fistula. We usually finish by about 10 a.m. Walk around, see the patients with the chief resident. I also have the task of reading the vascular labs for our hospital, which are the duplex ultrasounds that we do. I didn't get into that so much as far as like reading vascular labs, and I don't think Dr. Dorsey mentioned it either, but it is a big part of our job, which is actually interpreting the ultrasounds that we do for lower extremity venous disease or arterial disease and things of that sort. And generally by 11 a.m., we've started our second case. You can advance the slide again. In the afternoon, 1 o'clock, we're finishing up the second case, grabbing lunch, reading additional vascular lab, and between 2 and 4 p.m., we're either doing a third case or seeing patients, more consults, or coordinating care for the cases for the next day. Around 4 p.m., we generally have another meeting in the hospital, which is a chief's meeting. 5 o'clock, I'm finishing up the rest of the vascular lab studies and hopefully heading for home around 5:30 or so. And obviously this varies from day to day depending on the length of the cases and what we decided to book. And what comes in as an emergency as well. By 6 o'clock, generally hoping to have dinner with my daughter, give her a bath. And then by 7 p.m., maybe another Zoom meeting. And this has been a new thing for me. I don't know how it is for everyone else, but since I'm on the East Coast, a lot of these meetings that we have with our colleagues from across the country, they tend to be on the later side for us and maybe on the earlier side for them because we're in a 3-hour time difference. So it's kind of been like an added obstacle to the day, I guess, is sort of fitting that in. You can advance the slide. So in general, just case mix for me of the different kind of cases I do. I'm similar to Dr. Dorsey where I'm in a inner city area in serving a community with maybe a more socioeconomic depressed background. I'm currently the only vascular surgeon who's at Bellevue full time. So I'm kind of the jack of all trade for our specialty. So my practice consists of AV fistulas, endovascular revascularizations, traumas, revascularizations, bleeding control, dissections, transections. I'll also include intra-op consults into this, this category. I'll give you an example. Just on Tuesday, in addition to the 3 cases that we had booked, I also was called for an emergency into the peds orthopedic room and then called for an emergency in the cath lab as well. So we're kind of running all over the place and sort of helping out our colleagues as was mentioned. Any issues with bleeding or loss of pulses, they, you know, don't hesitate to come run into our room and grab us. We do AAA repair, both open and endovascular. We do thoracic aortic repair, again, both open and endovascular. We do carotids. We also, as I mentioned before, we do the RFAs on the veins, venous ablations. We also do venous thrombectomy and stenting, and then amputations. And then I think I forgot to mention what was on the last slide, but this picture here that I have is, if you can go back one, this picture that I have up here is just of intravascular ultrasound, which might be one of my favorite modalities to use in the operating room. And this is showing a picture of an aortic dissection before and after repair with a stent graft. So you can kind of see how the lumen, the wall around the little circle in the middle, has improved in the picture on the right, and it's bigger, and we revascularized his SMA. Okay, now you can move on to the next slide. So other things I like to get done during the week, if and when I have time, is mentoring with the fellows and the medical students, as well as research involved in clinical research. I also do a fair amount of teaching with the medical students and the residents. I do both didactic teaching as well as just small little lectures and attending rounds that we do, and then as well case planning. So I also have to fit time in the week to meet with the device reps or with my fellow colleagues to kind of discuss cases, decide the plan, especially with joint cases that we may do with cardiac surgery, or, you know, in the case of the tumor, with surgical oncology or whoever needs our help. So we kind of spend a fair amount of time discussing cases that are coming up and the best approach and things like that. The picture that's up on this slide is just of the same aortic dissection with the stent graft placed. And you can kind of see flow now return to the true lumen. And you can go to the next slide. And then outside of the hospital, just on like a personal level, I think my living situation might be a little bit different than others. I live in New York City, so we live in Williamsburg on the East River in Brooklyn. This is a picture of my daughter and my dog. So obviously time to have a family. I have a car, and for most of you that probably doesn't seem like a big deal, but in New York City, that might be a little bit different form of transportation. So I generally do drive to work, even though I'm just across the river. My other choices are to take the train or the ferry, but they generally don't start early enough in the morning for me to get to work. As I mentioned, I'm married. I have my daughter, Charlotte, my dog, Sydney. They are best friends. And just on a personal level, we do a fair amount of traveling, running and cycling and stuff like that. So there's definitely a social life outside of the operating room as well. And I think that was the end of my slides. Are you able to advance any further?
Correct. That's the last slide.
Okay, great. I don't know if you guys have any questions or if I went through that too quickly, but please, if you do, enter them into the chat, and I'm happy to answer anything.
That was awesome, Joni, and happy birthday. That reflects the dedication of our specialty, working on your birthday, and beautiful, beautiful daughter. Please, if you have any questions, put them in the Q&A. We'll try to get to them after Dr. Escobar's talk. Next, we have Dr. Guillermo Escobar, who's Associate Professor of Surgery and the Program Director of the Vascular Surgery Fellowship and the Vascular Surgery Residency at Emory University School of Medicine. Dr. Escobar's presentation is titled, "Which Vascular Surgery Training Program is Right for Me?" Dr. Escobar, please go ahead and share your presentation with us.
Thank you very much. Sorry, when I clicked on one thing and something else clicked on top. All right. Thank you very much for the invitation. Let me move this thing out of the way. So you forgot early specialization program, Dr. Kabani, but I'm going to talk about that a little further. So I have no disclosures. And, you know, somebody actually asked in the chat, how do you normally become a vascular surgeon? Well, all of you will graduate from medical school, and you can then go and do a 5-year categorical general surgery residency program, and then you complete a 2-year vascular surgery residency or fellowship, right? But the other option is that you can go straight from medical school and do a 5-year categorical vascular surgery residency, finish in 5 years, and there's yet another one. There's a couple places out there. There's 3 centers to my knowledge that you can do 4 years of general surgery via the early specialization program, and subsequently go on and do your fellowship for 2 more years. You can also throw in a little research here and there in different stages of your career. They can be between medical school and surgery, or they can be between during your general surgery fellowship, or you can pepper it in with your vascular surgery residency. So one easy difference when you're trying to say, well, which are my options or how should I do this? You can do an integrated vascular program. It takes 5 years. You could do general surgery first and then do a vascular surgery fellowship. That takes somewhere between 6 to 7 years, depending if you do an ESP or not. And then if you add research, or there's some places where they'll let you take a year and you may want to do a critical care fellowship like Dr. Kabani did, or you may want to do some other sort of get a master's in public health or something to that effect. So you can add to this time. If you sort of compare the overall characteristics of what an integrated program versus a traditional, the integrated started in 2007. You could easily say it's faster. You could say it's more focused. You have to do 1.5 years of general surgery, but the rest of the time is going to be focused on vascular surgery rotations. Theoretically, you have a lot more time to gain endo skill. You've got 3.5, 4 years of really 5 years, I guess, chronologically to do endovascular procedures. You have more time to master medical management, knowledge bases associated with the complexities of vascular surgery. However, people will often say, yeah, but you're less facile with open abdominal exposures. You don't really know how to manage, you know, TPN and drains and all these sort of things related to general surgery. In that light, if you start out with a fellowship route, which officially started in 1985, by definition, it's longer. However, when you finish, you have this broad-based knowledge and experience. You know, you do endocrine surgery, you do colorectal surgery, you do all these different aspects associated with surgery of the body in a whole. However, it does have this sort of vertical learning curve, right? You do 5 years and then you're supposed to know it all in 2. By definition, you have theoretically less time to learn all the nuances of endovascular or medical management related to vascular disease. However, you do gain this sense of greater comfort, if you will, with open exposure and management, which theoretically will lead you to be a more mature as a surgeon leader. By definition, if you do 7 years of surgical training, you come out as a more mature surgeon. So these are sort of the, from 10,000 foot view, what it really looks like. But really what you want to know is which one's better, right? And a lot of times there's a lot of stories out there about, oh, this one's better, that one's better, and all these things that I just told you. So objectively, a publication from 2017 wanted to look at what is the vascular operative experience, right? I told you one is 3.5 years of vascular surgery, the other one is only 2. So in a publication comparing the integrated vascular residency operating versus a traditional, this is based on case logs, which by definition, you will soon become poor case loggers when you all start your residencies and your fellowships. But looking just at case logs from 2012 and 2014 graduates, the average total cases by the vascular surgery residents compared to the vascular surgery fellows was almost identical, no difference. When they sort of looked at major categories that we often talk about, there were only a few that stood out as statistically significant. And what they basically were is if you looked at the total number of peripheral obstructive, this is a bad number, try this one. You notice that there's more of the major there as far as the extra-anatomic, which is when you do a bypass through a different part of the body what would normally, like subcutaneously from axillary to the femoral or things like that. They tend to do more of those, more thrombolysis, more vascular trauma, but by 8, not very much. Basically, a few numbers here and there over the greater period of time. However, when you look at it objectively, there is no difference. So when you look at the major vascular cases in each 695 versus 616, yes, there are more over time, but in the end, there was no difference. A classical comment is, yeah, but you're going to do more open exposures as a vascular surgeon who does a fellowship. Actually, the open abdominal procedures, both mesenteric and aortic, et cetera, were the same. So really, from a vascular operative experience, there is no difference in the big picture. In the little picture, you could say that as a resident, you might do more procedures. Well, what about vascular surgery attrition, right? You go into a vascular surgery residency and you quit. How often does that happen? Well, the good news is not very often. Very, very, very low percentage of integrated vascular residents will quit or change specialty. Within the realm of vascular fellows, same thing, pretty low. Somewhere in the range of 1% on average, plus minus 0.5, somewhere in there. If you look as a comparison, general surgery residents or cardiothoracic fellows, it was higher, somewhere in the range of 3 to as high as 9%. So generally speaking, if you go into vascular surgery, you're probably going to be happy carrying a cake of the aorta. What about the quality of care? I told you that there's different years and this and that. And if you look at a study that was published just recently in December 2020, what they did is they look at graduates from 2013 to 2017. So recent graduates, using the American Board of Surgery, we knew who graduated and who was board certified. Then what they did is that they used this Vascular Quality Initiative database, which is a prospectively collected outcomes database for vascular surgery procedures. And they said, all right, let's look at fellows that graduated and residents that graduated, and let's see which one had better outcomes, more complications, or vice versa. They looked at mortality, major adverse cardiac events, or major complications. They had 338 surgeons that graduated. About a third of them were residents, 2/3 of them were fellows. And what they found? No difference. No difference in the number of cases that they did for a year after they graduated, and no difference in the outcomes. Quality of care, the same. So basically, both are good paradigms. You will have the same number of experiences, the same quality. What else should you think about? What about academic versus private, doing research? What if I can't get in? If you go into academic, it tends to be more competitive. You have greater interactions with learners. You have medical students, more residents. It's going to focus and expect you to do academic activities like the one we're doing here, and they'll be more inclined to let you go. And letters of recommendation are going to be nationally recognized. They're going to be people that, well, go to meetings and people know people. If you go to a community program, it's generally less competitive. You're going to do more cases. You tend to operate a lot more. You generally have more perks, right? You have a better a lounge. You have more nice amenities in the the community hospitals. And you generally have a little bit more help around, and/or the attendings are kind of a little bit more independent. A lot of them, one of the fallacies people think is that you're only going to, if you go to an academic, is the only place that you're going to do like new trials and things like that. And that's actually not true. A lot of the community centers are so high volume that they actually become very, very important when it comes to doing trials and doing fancy new devices and things like that. If you were to get later, you want to be an academic surgeon, what's a lot better? You become more competitive. You leave an academic to stay in an academic. You have greater expectations as far as documentation. You'll be doing more stuff. You'll be managing the patients more one-on-one. And it is usually likely to be a trial center. Generally, you have a little bit less cases. Generally, you have a few less perks. Again, community, generally, you're going to have the newest tech. You're going to have less interaction with learners. And there's a little bit less focus and expectation for you to do things outside. Maybe or maybe not, depends on the center. You might be less inclined to go to meetings. And your letter of recommendation may or may not be less recognized. Now, there are huge community hospitals that are unbelievably academic, but these are totally just broad-based things. To do research, it adds more time, but it's time for you to be normal. And sometimes it's kind of nice to balance the intensity of training. If you do 3 or 4 years of intense training, and then you take a year or 2 and do research, that's time a lot of people will travel the world, they'll get married, or just simply be a normal person for a while. It lets you attend meetings far more freely. It lets you present, learn, publish. It lets you do more academic things, a little bit more on a regular schedule, and you have a lot more interactions with the staff. What's really funny is when people come out of research, they generally are much more less intimidated with the staff because they spend a lot more time with them. It also expands your mind, in my opinion, and your experience for problem solving. If you want to do research later on, having done research during your training will help you for academic positions in grad, but it adds more time. And if you don't really have a lot of interest in research, it may not be something for you. But a huge fallacy is that you lose technical or clinical skill. A lot of us have done research, and we're okay. So the bottom line, there is no objective difference in vascular training. You may gain a more broad surgical knowledge with a 5 or 2 or the 4+2 when you do general surgery. And to be honest, that might give you some more job opportunities. If you want to go work at a small hospital and you want to do general surgery and take call in general surgery, or you have a military commitment and you're going to be put in the field, having that extra training and extra knowledge is probably good. But on a day-to-day basis, I can tell you that the majority of vascular surgeons really don't do a lot of general surgery. And if you get a case where it's complicated and you have to do something, you can always partner with your general surgery colleagues. Some programs offer optional research, or they may say a mandatory research. So look into that carefully when you're applying to these programs. If you're thinking about research, an optional research place might be good. If you're sure you're going to do it, then apply for places that are going to give it to you. Some will also give you that extra time, like I told you. And personally, I support research. You can tell I do have one bias. So I have no disclosure, but I do have bias. And what if you don't match right away? You wanted integrated, but you didn't get it. Or you wanted categorical, but you didn't get it. You wanted a Ferrari, but you didn't get it. The reality is you don't always get what you want. And I'll just very quickly just mention this part right here. If you graduate from medical school and you don't get what you want, you can do preliminary residency for 1 or 2 years. And that may help you get back into a categorical general surgery or vascular surgery. You may or may not do research somewhere in there. Or you can do research immediately after medical school and go out. And don't worry about it. It's not the end of the world. There's other ways to get in. And with that, I will return the microphone back to Dr. Kamani. Thank you very much.
Thanks, Guillermo. Really appreciate it. And as always, love seeing the slides that you've put together. So if we can have Drs. Dorsey and Drs. Lugo turn their video back on. We've got a few questions that have been somewhat answered in the chat, but some good things that we might just want to ask to the panelists to get a different perspective. So Loa, is it okay if I pull up one of these from the Q&A quickly that I've been looking at for a few minutes?
Yeah, please do. Guillermo, come on up. We want to see your lovely face, please.
We've got, say, 4 screens going on, and I don't know which one to look at right now. But all right, there's one question that was great asked by Dr. Lee to Chelsea and Joni. Both different pathways, both very successful, both doing fantastic things at great institutions. The question was, when did you guys decide to go into vascular surgery, and sort of what was your path to get there? And I'll field this perhaps first to Chelsea, because I think Joni already put something in the chat briefly, and then we'll flip back if that's okay.
Sure. So I came into medical school thinking that I was going to be a psychiatrist. And then I loved anatomy class and realized that I loved working with my hands. My year was actually the first year that they had put up these huge flat screen TVs in our anatomy lab. And so I realized pretty quickly, because they had integrated a radiology component, that I really love going back and forth between imaging and the body. So I knew that I wanted some kind of specialty with imaging. So I thought interventional radiology for a period of time, until I realized that I did want longitudinal care of patients. So, and then I kind of went through all the other great things about vascular, like the variety and things like that, that really drew me to the field.
Awesome. And Joni, what's your insight? Who drew you to vascular surgery?
Yeah, so I feel like it was a little bit different for me. There was no such thing as an integrated program when I was applying to residency. I think the first class may have been the year after me, or maybe the 2 years after me. So it was something that was slightly talked about, but wasn't really an option. I know I had a friend who purposely took off time between medical school and residency and did research so that he could apply to an integrated program for vascular surgery, and then ended up going into transplant. But anyway, I mean, lots of things can change your mind along the way, but I didn't have that option. So I chose general surgery because I wasn't really sure like what I wanted to specialize in. Like Chelsea, I was really into anatomy. I looked at a lot of different specialties to try and find something other than surgery to do, because people kind of scared us back then about doing surgery and how we wouldn't have a life or wouldn't have a family. And obviously none of those things are true, as I showed you guys. But I chose general surgery, and then vascular surgery really came because of mentorship for me. The attendings that I had in my general surgery training program who were the vascular surgeons for one reason or another were the ones who took the most interest in us. We had a small program and were really, really involved in the operating room and really involved in teaching and training and basically telling us every day why their subspecialty was awesome and why they were just like the kings of the hospital. And it was basically what Chelsea highlighted. There's nowhere in the body we can't operate, nobody we can't rescue for the most part. And when you have that kind of mentorship, I think it really draws you into the field. So that's kind of what did it for me. And as well, I think it really complements general surgery because you are operating on all over the body and you are, continuing to see the bowel and the colon and things in your face. And so you have to be familiar with general surgery. And so it really built upon that. And then as well as we were mentioning in the comments, you're still coordinating with your colleagues and you're still collaborating. So you're still doing cases with surgical oncology, or you're doing cases with ortho or urology or ENT. And so you really are able to do these things. So I didn't feel like I wasted 5 years of general surgery to go into vascular surgery. I actually felt like it really turned me into a better surgeon, made me more capable. And I'll tell you now as an attending, I mean, I love the integrated residents because they're smart and they're dedicated to vascular surgery and they're fierce about research. But I love operating with the fellows. I love it. I can't tell you how nice it is when I'm in the middle of a trauma case and a fellow walks into the room and it's like he or her wearing a cape and coming in like Batman to rescue the day because they're trained surgeons and they're just so skilled. So I think it's just a good compliment, and I like both pathways and I love working with both pathways. And I don't know if I got off track to answering that question, but I'll stop now.
No, that was awesome. So I had a question in the question box from Alan Michael, and this is to Dr. Escobar. How many research projects do you complete before applying? So when you're looking at your residents or your fellows, how much research do you think that they need to do before they apply to vascular surgery? Also, what things did you show that have an interest? So what things that can differentiate an applicant with the hundreds of applicants you get at Emory? And I would also ask you, Guillermo, if you can shortly tell us what got you interested in vascular.
So I'll start with the last one first. So I hate that question because it's never really fair. It's sort of like you, Loie. My parents were cardiovascular surgeons. They were trained, back in the day when you did the heart and the periphery, when all you had to do was open surgery. So I have the uncommon exposure that, I mean, even like in high school and college, I was able to sort of like, learn from my parents, and they were both cardiovascular surgeons. So by the time I was in medical school, I was able to operate with both of them, and I absolutely fell in love with it. But to be honest, I just love the cardiovascular physiology. I love the pharmacology. I love the aspect of, this receptor does this and that receptor does that, and the fluid dynamics, and like that part of physiology I just really, really liked, independently of my parents. But I definitely had a false influence that not everyone would necessarily get. As far as like, what do you need to do to apply? The way I look at it, I actually have a whole nother slide set on what you need to do sort of to be competitive. But the more of these boxes you check off, the more competitive you become. And people think that, oh, if you didn't, publish 3 papers or only in vascular surgery, I can tell you that doesn't bother me that much. If you have a publication because you had a really good mentor in ortho, and you presented on a podium on a topic of, I don't know, psychiatric problems of, you know, migrating geese, that doesn't matter to me. That just shows that you did something a little bit more than the other person who has the exact same scores that you do, that has the exact same school that you come from, that has the exact same background that you do. So what I would tell you is that if you can get involved in a project that you like, and you presented it on a podium or a poster, and you got it to publication, even if you're a second or third author, if you get first author, that's even better. But I don't necessarily count them. But the more that you can do during your time, the better. And the best thing I can tell you is that if you're ever on rounds on any service of any specialty, and somebody says, huh, that's funny, never saw that before, you got to grab that and say, wait a minute, really? Tell me more. Can I publish it? Can I do something with it? And take it to the next level. And that sort of makes you stand out in an application, just from an academic perspective. But no, you don't feel like somebody wrote in there that, oh, I'm a third year and I'm late, and you know, I didn't fall in love with vascular surgery early enough. As a program director, I don't care. If you have, you know, again, publications on migrating geese, but you know, it's on there, then you did a little more than the other person. So don't be intimidated by that. Some program directors will say, oh, you know, they're not dedicated, but I think that's false.
Awesome. We're going to, for the sake of time, we're going to move on. Thanks to our three presenters. We're going to go up to some case presentations. Next up, we're going to hear some interesting cases. Our first case is from Khalid Diab. He joins us from Houston Methodist Hospital, and he's going to talk to us about an interesting endovascular case he's done. Khalid, it's all yours.
All right, let me just go ahead and pull up my slides. And I thank you all for attending this VSIG Live. I hope everybody can see my slides okay.
We can.
So, all right, so my name is Khalid Diab. I'm a third year here, integrated vascular surgery resident at Houston Methodist. And I'll be talking to you guys through an endovascular interesting case that we don't see too often, but it's pretty nice to go over. Have no disclosures. So the patient was a 22-year-old, presented with about 6-month history of right arm soreness near a lump that she noticed in the past year or so. Her symptoms seemed to get worse over that period, and then became pretty much debilitating for her. So she is also right-handed, so she presented for further evaluation to us. Really no major relevant history here to go over. On her exam, she had that small lump that she mentioned, somewhat tender to palpation, kind of on the lateral side of her upper arm, and otherwise she had palpable radial and ulnar pulses down her hand. So just to go briefly over, we did an ultrasound here which shows color disturbance, as well as kind of, I'm not going to get into details here, but this is a duplex that we look at. This is a normal duplex, something that we call a triphasic signal is what you want to look for. You can see here it's a different sort of presentation, and those sort of characteristics lead you to think that you have some sort of arteriovenous communication or an AVM, arteriovenous malformation. So this is kind of a picture here of it, and you can see how the blood tends to be shunted away from the normal vessels. And I'll run this video here to show you. So this, the product that's used is called Onyx, which is a non-adhesive liquid embolic agent. And then whenever you put it into any sort of aqueous solution, whether it's blood or water, as you saw here, it tends to become a spongy embolus, and that prevents the blood from coming into this and feeding into this arteriovenous malformation. What we did is an angiogram of the right arm, and then we did embolization of that arteriovenous malformation, which I'll show the procedure in a second, to go ahead and stop the blood flow towards this arteriovenous malformation. So just generally, most of the procedure that we do endovascularly could be accessed kind of from this area here, and around the femoral area. And you use ultrasound, you go up with catheters wire, depending on where you're trying to go, up and down. If you're trying to go to the other leg, in our case, we were trying to come down here to the arm, do the angiogram and see better what's going on. So we went up here into the right subclavian, and we kind of parked our catheter here. That'll start showing the images. Quick MRA was, I'll show here the images of this MRA. Here you can see that arteriovenous malformation. It'll be pointed out right here in a second. So as you see here, there's a catheter. That's what I was talking about. We parked our catheter and then we started with the angiogram where we inject contrast into the arteries, and with the x-ray, you can see what's going on. So pretty much here, you're supposed to see the artery, the blood flow coming down to the arm, whereas in this case, you see two branches here coming off and feeding this arteriovenous malformation. And in a second here, you'll see, so this is the axillary artery, brachial artery, and you have a branch brachial and a branch from up here that comes in and feeds this arteriovenous malformation. So again, a couple of more angiogram to better understand the anatomy. We get some of those more sheath into the area we're working in to get some support to do whatever we're trying to do. So in this case, we are gonna focus on first selecting this branch here. You see with our wires, you go into here and then you use a microcatheter. I'll go ahead and fast forward through this here. So once you get your microcatheter, you wanna do an angiogram through this area to confirm that you're in the right branch that you want to start embolizing, meaning that you want to go ahead and block the blood flow to that area, as you see here. Because once you do that, you're pretty much, there's no point of return because you already blocked the flow to this area. So go ahead and forward here. So you can start some of that. Black filling material is the onyx embolizing material that's going into those branches that we're trying to occlude. And in a minute here, I'll show a repeat angiogram, which will show you how there's no more flow into that area. So more onyx, it's usually given at a slow rate. You don't want to embolize it to your normal arteries and cause problems downstream. So once we're done embolizing this area, we'll get it to an angiogram in a second here. So you can see flow and it stops right about here. No more flow into the area that we embolized. Once we finish this area up here, we come focus on this branch. Same procedure, we start embolizing and you'll shortly start seeing some of the onyx embolizing material come into play here. Again, confirm where you're at before you start embolizing. So going forward here, we put the microcatheter and you can start seeing us put some onyx material to fill up this branch up here. Once that is done, we do a completion angiogram, meaning that you want to look at your results and see if you're satisfied with what you blocked the flow to stop this AV malformation. And you see more blood flow going downstream the arm as it should and less into that arteriovenous malformation. The patient was discharged on post-op day 1 the next day, and her 1 and 3 month follow-up, she reported improved overall symptoms, no more soreness in her arm, and then her physical exam showed distal perfusion, meaning palpable pulses in her right arm. Again, thank you for attending this. I'll be happy to answer any questions.
Thanks, Cal. That was awesome. Really interesting case. And for those of you who haven't seen anything like that before, really you just look at the pictures and you can obviously sort of see pretty quickly that they've done a great job through a very tiny little incision. Well, we'll move on now to Dr. Erin Greenleaf. She's a second-year vascular surgery fellow at WashU. Dr. Greenleaf will share an interesting open case and sort of provide the other portion of it. Thanks, Erin, for being here. Take it away, Dr. Greenleaf.
Great, thank you so much. Hello, everybody. I'm Erin Greenleaf. I'm a second-year vascular surgery fellow at WashU in St. Louis. I think you'll see some commonalities between mine and Dr. Diab's presentations, but fair bit of differences. Today, I'll be presenting a case that sort of highlights some of the broad operative capabilities we have as vascular surgeons. Let's see, can we advance? There we go. So to begin, our patient is a 60-year-old male who presented with a progressively enlarging lower abdominal mass. He came to medical attention because he was having symptoms consistent with a partial bowel obstruction, outflow obstruction of his transplant kidney, and bilateral lower extremity swelling. The patient's relevant history is significant for having chronic renal failure, for which, as mentioned, he underwent a renal transplant onto his right external iliac artery and vein a number of years prior, but that due to the compression from this enlarging mass, he had required a percutaneous nephrostomy tube, but ultimately, his renal function had degraded to the point of needing to go back on hemodialysis. His other medical history, he kind of had the usual comorbidities, heart failure, coronary artery disease, hypertension, COPD, and history of tobacco use. So not uncommon to kind of our typical patient population. So this is, the patient was admitted preoperatively and underwent a CTA. I'll just, let you run through the axial cuts here, and it'll probably get your attention. Then we'll go back through slowly. You notice that there's a large midline abdominal mass. It was, let's see. It was, I'm sorry, I'm trying to go back through. Here we go. We'll go slow through it. So in the lower midline, you can see that the mass comes in. It's adjacent to this massively dilated left hypogastric artery or internal iliac artery right here, thought to be coming off of it. You can see his transplant kidney on the right over here. It's fairly compressed with some hydronephrosis. You can also note that, just going back, his colon, his sigmoid colon pretty much disappears into nothing. So he had a bowel obstruction, partial bowel obstruction, and then his venous drainage was compressed as well. So that was his preoperative scan. Given the radiologic characteristics, it was thought that this was some sort of large aneurysmal pelvic AV malformation with feeding vessels off of the IMA, the middle sacral, and the bilateral hypogastric arteries. So the patient was ultimately taken to the OR. You can get a sense from this picture, this pre-op picture, the scope of kind of what we were dealing with. The plan was ultimately we had to decompress this mass because, that was essentially why he was presenting to medical attention. But we needed to make sure we could safely do this by getting control of the inflow. So the plan was to embolize all of the feeding vessels, or as many as possible, and then performing a laparotomy to decompress the mass and hopefully sort of marsupialize or plicate it. So from a left femoral approach, we performed sort of the endovascular portion of the procedure. We did an aorto-iliac angiogram. You could see the image on the left with a fairly sizable IMA coming down. We saw engorgement of multiple feeding vessels, including the IMA and the middle sacral on the right here, which we then used a series of sheaths and catheters and wires in order to deploy a bunch of coils in order to embolize all of them. These are just some representative cuts from the angiogram. The right hypogastric artery, anterior and posterior division, we coiled that. We coiled branches off the left hypogastric, and just, a couple of images to show that we used no lack of or no shortage of coils. I think we sort of ran through our entire stock to try to get control of this thing before we open the patient's belly. So then we proceeded with the open portion, and just to be safe, we placed an occlusive balloon in the aorta to make sure that we had proximal control before getting in. We noted that the aneurysmal malformation was, had this very thin and friable wall, and, we'll just run through this video, let it play. And so you can see it, the slightest bit of pressure here. This is a video of the open portion. We obviously didn't get all of the feeding vessels. We found, there was a significant number of feeders into this thing and lost about 4 liters of blood in about 10 seconds, but was able to pack it. We subsequently resected much of the aneurysm wall, suture ligated the posterior feeding arteries, and subsequently closed up. So I'll just scroll through quickly so you can see how thin this wall is. Essentially, after closing, the patient did great. He was taken to the ICU, spent a few days there, was only in the hospital for about a week, where he resolved all of his symptoms. He was having bowel function. He was making adequate amounts of urine, and his legs had decreased to about half the size that they were on presentation. We saw him in clinic a month later, where he had recovered well and had complete resolution of all of his preoperative symptoms. These are, some representative axial cuts of his post-op scan. You can see that the mass is pretty much gone. in its place, we see a lot of coils here causing a bunch of artifact. And on the sagittal cut, again, mass is gone. He pretty much has a flat abdomen rather than the protuberant one. Bunch of coils in his transplant kidneys, nicely decompressed, no hydronephrosis, as well as his colon is, while constipated, it's still moving stuff through. So in summary, this is a 60-year-old male who presented with a unusual pathology for which we used a hybrid approach to give him a durable solution. He had a good outcome, and it was a pretty successful case. Thank you.
That was awesome. Thank you, Erin. It really shows what we can do as vascular surgeons. We have the endo technology and we have the open technology. You can take care of the whole patient and the whole disease process. Really nice case. Our final presenter for the evening is Dr. Benjamin Pierce. He, along with Don Coleman, started the VSIG symposium last year, and that which got canceled from COVID. But again, we were able to resurrect it this year. Dr. Pierce is the program director for vascular surgery at the University of Alabama School of Medicine, and his presentation is titled "How to Maintain a Successful VSIG at Your Institution." So VSIG stands for Vascular Surgery Interest Group. Ben, it's all yours.
Perfect. Thank you, Loie. Pete, can you start it maybe not in presenter views? There's a few of the, there you go. So I think I got asked to talk because Loie's right. I took over this, they took over this committee, from Dawn and I, and we took it over from Mal. And there's a whole history of just wonderful people. And it's like the Academy Awards. I can't thank all the people that I would need to thank, so I probably will stop trying to name names. But vascular surgery, and you've heard a lot of great presentations tonight, and I think you see a lot of the reasons that make it exciting. But some of the reasons that I think hurt our sort of exposure in the medical school world, right? There are so many different ways to do what we do that sometimes I think it gets confusing to people. And that's where I think your vascular surgery interest group can really make a huge difference. I mean, we just had 2 cases. I was 14 years of doing just vascular surgery practice. Those are 2 cases I haven't done, right? And we didn't touch on all the stuff that we do kind of routinely, and that just shows you how diverse it is. But again, sometimes I think that makes it hard to define who we are, and that's where your vascular surgery interest group can come into play. So what is a vascular surgery interest group? I think that the thing to remember is that we're the champions of vascular surgery, right? Both the students who are involved and the faculty mentors that you have, we can be champions for vascular surgery. And you need more than one champion to make a vascular surgery interest group work. So you have to have a faculty champion, and I would argue you need to have at least 2 faculty champions, because you saw Dr. Lugo's talk, right? Her day is full, and that's a good thing. It's great to wake up in the morning, go to work, and then all of a sudden you look up and it's 6:30 at night, and hopefully, like I said, you're home feeding your kids, unless you're on call, in which case you're probably replacing a carotid artery because bullet just passed through it or something like that. But you look up and the day's gone, and that's usually a sign of something exciting has happened. So I've been really lucky that I now have some junior partners and an associate program director who is just like totally awesome and a wonderful academic and wants to teach. And so, she's helping me with this. And then we've been really fortunate to have student champions. And that's where hopefully we have some of each on the call. We have faculty at schools and I think hopefully a lot of students on this call tonight. But as the student, you can be champions too. Because again, at the end of the day, everybody's busy. As students, we know you're super busy. But you need to help push us to do this. And I know a couple of our students are on the call, and they're helping to get us motivated again in what I like to call LAZ, or life after Zoom. We kind of all, I think, went on a big pause with these sort of initiatives, and it's time to get them started again. So it takes champions to make this happen. And why does vascular surgery need this? You've heard a lot about it tonight. But, you know, surgery is really only a small part of who we are and what we do. And vascular has an identity problem. Dr. Dorsey spoke to that in her talk. And like I said, there's almost too much that we do to make it sometimes hard to define. People know what an orthopedist is. People know what a plastic surgeon is. People know what a cardiologist is. Even the patients don't know. And so I think it's really critical that we have these groups together to help define who we are and to get the next generation of vascular surgeons out there. And you're already demonstrating that you're interested in vascular surgery by being on this call. And I ask you to go to YouTube at some point this next weekend and watch the 2016 SVS presidential address that was given by Dr. Bruce Perler, P-E-R-L-E-R, in case you need to search for it. I put that link there. Maybe they can send that out as a follow-up. But his talk was, we care. And I think nothing defines us better than that. And that's what our identity should be. And that's what the Vascular Surgery Interest Group at your institution can do, is help define how it is that we care. How do you get this started? There's actually on the SVS website, this committee has done a tremendous job of kind of updating the best practices, if you will, for how to start and how to maintain a VSIG. And I don't want to bore you with all the details of that. You can go to the SVS website and you can look this up. But it's really important. And it's important to have this because you got to reach students in the preclinical year. And so if you're a student on this call and you don't have vascular surgeons giving your preclinical talk on vascular surgery topics, claudication, the natural history and treatment of aneurysm disease, carotid stenosis, you need to go to your course directors and say, why aren't the vascular surgeons giving these talks? And if you're a vascular surgeon on this call who's at an institution that has medical students, you need to find the people who make up the curriculum, and you need to be asked to get on there. The reason our VSIG has worked in the past is because my predecessor before me, Dr. Jordan, did just that. He went to the curriculum people and he said, wait a second, you can't have anybody but a vascular surgeon talking about vascular disease. And so he started giving these lectures, and I've been lucky enough to inherit these lectures when I took over as program director. But these are just simple things, you know. It's the lecture on claudication, it's the lecture on aneurysms, the lecture on chronic mesenteric insufficiency. The other thing is that when you see a career mentoring type thing, when you're faculty and you get one of these emails and you think you should delete without reading, please don't do that. Get you or your associate program director or one of your faculty to please go whenever there's a mentoring meeting, whenever there's any chance to touch medical students' lives at an early stage or any stage of medical school, do it. And again, if you're on this call tonight and there's going to be a mentoring thing at your school and you don't see a vascular surgeon listed, email them back and say, hey, I really think it'd be great if a vascular surgeon was here. You know, when there's mock interviews for residencies or for those things, you want to make sure that one of you guys is involved and one of your faculty is involved. You need to partner too, though, right? It's no fun if there's just one of you involved. So as much as I think Coach K is the epitome of what a leader should be, it's much better and a lot more fun when your rival is good too. And so you need partners. You know, we have a really strong surgery interest group at our school, and most schools that have a general surgery program will have a vascular surgery program. And so, or if you have a vascular surgery, you're almost always going to have a general surgery program. And the surgery interest groups are going to pull a larger amount of students because, again, people know surgery. They grew up hearing about surgery. One of my faculty, when I was a general surgery resident, said everybody wants to be a surgeon when they start. They just don't have what it takes to do it. And I think that's probably right. Most people growing up, they don't think, oh, I think, you know, I want to be radiology and just sit in the room and read films. They want to do things. And so the surgery interest groups can be a great partner for you. Again, get involved. I actually hosted the surgery interest group dinner at our house this year. We rotated amongst the different specialties, and I think that's a great way to do it. But again, if you're going to the surgery interest group functions, feel free to ask if anybody in the room is a vascular surgeon, and if not, ask the person who put together why not. Another great partner is your industry partners, and I can I'll show you just some pictures that explain why. But the folks that make some of those devices, again, that our trainees that presented tonight touched on a few of the things they use. There are some pretty big, pretty high dollar devices that are used in vascular surgery, most of them revolving around treatment of peripheral vascular disease or treatment of aneurysm disease. And those companies, it's in their best interest to support the training. They want the next generation of doctors to think about. And so they can bring you simulators, they can bring you expired graft material, suture material, all kinds of stuff, expired stents, expired balloons that you can use to practice. And those sort of events are great. In fact, those sort of things are easy to do. Most of the things, we did a poll of the program directors, and we found that of the programs that have vascular surgery interest groups, that the things that really work aren't that expensive. It's not that much. What it takes is a little bit of time, a little bit of effort, but just simple things like meeting and greeting and buying pizza and having just a talk during lunch. Those were things that were really well attended for us. Doing interesting case presentations. We're lucky. We're revamping and rebooting our interest group in the Zoom platform, and we're going to do case presentations with faculty-specific interests, and that's another way to just get people involved. And then again, these simulations, which the companies will provide for you. You don't have to spend $1. You just got to find a place to put the machines, and they will come and they will bring it from. We have had people bring their devices from Flagstaff, Arizona, and from Florida, and from California, and bring it to our little old home here in Birmingham, Alabama. And we do these on a quarterly basis, actually, with our residents, and once-a-year basis with our vascular surgery interest group. And those things are so beneficial. You know, these are kind of the models of the things that we do, and you see the smiles on the faces of the people that are doing this. I mean, it is really a lot of fun. I'll say it again, in the sort of the last great thing we were able to do here with our interest group in life before Zoom was we had our Alabama Vascular Society meeting partnered with our VSIG, and we had a simulation morning for medical students. We had students come from 5 states and over 50 students to do this with us. Med students, y'all are great. You guys want to learn and you want to be involved, and you're more savvy than we were when we were medical students, quite frankly, those of us on the call that predated integrated residency. And so we know that you'll be there. If we have a way for you to get one-on-one mentoring with a faculty member and put your hands on something and do something, you'll be there. And so these are really great things to do. I'll tell you something else we did at this last thing that was really great too, was we got our community partners to show up. We had a whole session, no slides, open mic, and our community partners and us, our private practice physicians, came in and we kind of explained that there's a lot of different ways to be a vascular surgeon. Again, Dr. Dorsey, I thought her talk was just really spectacular for people who are at your stage of learning, because you could have a practice that's predominantly a vein type thing. It could be complex veins, like some of what she showed in the hospital. It can be veins in your outpatient office. You can do artery work in your outpatient office. Depending on what your life needs to be for your family situation and who you are, there are some really viable career options that aren't sort of the every night trauma case, ortho-abdominal aneurysm. That being said, if you like those sorts of things, you can do them too. There's a lot of really neat ways, and it's great to hear from your community partners and get them to come talk to your medical students as well. At the end of the day, I think the most important thing to remember is about being a vascular surgeon and having a vascular surgery interest group, and the thing that will keep it going the most is remember that we care. We care about our patients. We have longitudinal relationship with our patients. We care about our medical school. We care about our partners. Our partners care about us, and we care about you and your learning, and we want you to be the next generation to sort of pick up the flag and carry it forward. So I will stop talking with that. I could talk all night about vascular surgery, and I hope you saw that kind of comes through in the theme of all the talks tonight. The people who do what we do are very interested. They're, like I said, they're interested in what their jobs are, thay're interested in their lives, and they're interested in your lives. So Loie and Jonathan, I can't thank you enough. This was something that was kind of handed down to you when you took over the committee, and you guys made it happen. And I really, really appreciate that. So with that, if there's any questions, I'll be happy to answer.
Well, Ben, thanks very much. If you're left without a warm and fuzzy feeling after that pep talk, then, you know, what more can we do? You know, we're a little bit over time. We have gone through, I think, a lot of the questions, and certainly I wanted to bring everyone back briefly. Erin, Guillermo, Chelsea, Joni, Cal, and let's say Loie is already on. Just to sort of wrap up, if there were any questions or any points that people wanted to raise. Again, Ben, thanks very much for you and Dawn laying the groundwork for this, and thanks for everybody sort of putting this together. Everyone's worked incredibly hard, and you know, on their weekends and days off and such to put this together. But I just wanted to see if there are any outstanding questions, Loie, that we should field in the few minutes we've got left, or if anybody wanted to sort of say any last words.
I think there were a lot of questions about the difference between interventional radiology and vascular surgery in the chat. I don't know if anyone wants to comment on that.
I guess I would say that, you know, we saw 2 great cases from our trainees, and they both kind of involved sort of what you could easily look at, it with the exception of poking a big hole in a huge aneurysm and sucking blood out. That takes a certain amount of intestinal fortitude to do that. But, you know, radiology looking type procedures, all the coiling and the embolization, that sort of stuff, you know, I think the difference between, right, the big difference is we can do all those things, but we can also take a knife and do the right thing when it's the right thing for the patient. And that's a great video to show, but it's usually not that dramatic, hopefully. You know, you get proximal distal control when you open things in a nice controlled fashion, but sometimes you don't have that luxury. But I think the biggest difference is that we're not pigeonholed into doing a procedure just because all we can do is that thing, right? We can do, that's what's so much fun about it. What we do is we can do the right thing for that patient, whether it's an operation, whether it's medical management, or whether it's endovascular therapy. And that really sets us apart. And I think, again, it also makes your future, if you're looking at your career arc, you know, what a future you have as a young person, right? You're never going to be out of a job or out of work.
Louis, can I expand a little bit?
Yeah, please.
If there's time. So regarding the question is, quote unquote, who gets to do that case if there's overlap, if interventional cardiology, radiology, neurointerventional, et cetera, does an endovascular case. I would tell you, having worked in 3 different institutions as an attending, is that there's going to be a lot of referral patterns such that everybody that gets a DVT gets a vascular consult in one place, and everybody gets a DVT might get an IR consult, or an occluded fistula may all go to IR in one place, or interventional nephrology at one of the places I trained. So there may be overlap as far as the technical ability, but the actual referral will depend on how you advertise your abilities, your skills, and show that you're good at something. You will tend to do whatever it is. But some institutions, just everybody used to call whatever, and therefore you may show up and have the skill, but you're not going to get as many referrals. So really what Ben said is the best part, right? You will be trained to do all the gamut of endovascular and the open stuff so that you can, you know, become the world's expert of AV fistulas, or you could be only the open aortic stuff or whatever. It's so varied. It's great.
Yeah, and I'm going to add one last comment. Is really what I enjoy about vascular surgery is the relationship I get with my patients. I had clinic yesterday, and I've been at my institution for about 10 years now. And it's so nice to see a patient I operated on 10 years ago come back and still be thankful that the operation still worked. So I think there's a lot to be said about having that relationship. You know, we're running very late. I want to thank everybody, especially the attendees, for attending, participating in this VSIG program. Have a great evening, everybody, and hope to see you again soon.
Thanks a lot.
Thanks, everyone. Really appreciate it.
Take care. Bye-bye.
Pete, thank you so much. That was really, really good.
Yeah, I'm not sure what happened with Dr. Lugo. I don't think she ever quite clicked on the slide, and unfortunately, I could hear the little dink, dink, and I think that just means her mouse, Ring Central is trying to control her mouse.
No, it worked fine. I don't think it made a big, you know, you handled that very nicely.
Yeah, thank you.
Joanna, thank you so much. That was really, really good. I'm happy we got so many attendees.
Yeah, no, it was great. I believe at the peak we had about 88 attendees that were on. So really good turnout.
Yeah.
Yeah, no, that was nice. We need to do another one of these probably about a month or two. I don't know. We have to kind of but that's part of the committee that we have to do is figure out how many VSIG lives we're going to do and how we're going to interact with the SVS for these things. But we should do at least 2 or 3 a year. I think that's about it. Thank you,
And I did
everybody.
send you some screen captures in your email.
Awesome.
So I
Awesome.
showed you the whole view at the beginning with the attendee and panelist thing. So.
Okay. Thank you so much, everybody. Much appreciated. Joanna, I'll see you tomorrow. And Peter, I guess I'll see you tomorrow.
Yep,
Yes,
we'll see you
see you
tomorrow.
then.
Thanks
Have a
so
good night.
much.
Bye.
Bye.
All right.
Hey, guys.
Hi. Great job,
everyone.
Woohoo.
He was happy, so that's good.
Yeah.
Yeah, no, I thought it went well.
Yeah, the question and answer thing was just cumbersome. I don't think they realized what they were getting. What's that?
Times. That's happened to us. I remember, and I kind of forgot about that, but I remembered our Delaware meeting that did happen where people type questions in the chat box instead of Q&A, and then I ended up having to like retype it in somehow. So yeah, I did forget about that. But
I think if we just stick with the plan and continue to encourage people, once they start answering on chat, that makes it a little difficult, but and plus, like I say, people are kind of distracted because they're trying to read. So anyway, I would say if we agree that we kind of want to keep directing them a Q&A, we could just send individual messages to the people that are sending them in chat and or to all attendees. So, we'll feel it out and see how it goes.
yeah, and we can even give JJ and Jason a heads up tomorrow just to let them know. I'm sure it's going to happen. I think there's you just kind of pick it like, oh, okay, I'm a chat.
Right. It's kind of right there and it's natural.
Yeah.
Exactly.
But that's why we have a couple moderators. So hopefully they will just kind of give them that heads up to just monitor that so that they could make sure it gets answered.
Yeah, and that's a good point. I think the other ones that Bex and I have done, there's only been one moderator, and it's nearly impossible for them to, watch both boxes and answer and still be the moderator. So maybe that made a difference with just an extra person.
Mm-hmm.
I think it does help, definitely.
No, they both did a great job. Jonathan was totally on it, so.
Good deal.
And they were obviously paying attention to the chat too, so because they did reply here and there. But I think you were right. Was it you, Joe, or someone asked me, is everyone seeing these messages? And I looked, and it looked like they were just replying to panelists, not panelists and attendees. So I sent a message out. Yeah. So it's tough because somebody sends you a text and you start typing and it goes to the person who you last interfaced with. So that happens.
Right. Well, and another good reason to just keep it in the Q&A so that everybody can see the answers or hear them.
Right. Yep.
Yeah.
Yep.
Okay.
So tomorrow, so you'll be coming on around 9 a.m. Central?
Yeah, I'll open everything up an hour early,
okay.
Just to get on and be sure it's working. That's always good.
Did anybody get any emails about not being able to log in tonight? Because I didn't see anything. So
nothing. Not a single one.
Okay, awesome.
That's great because this was the one we had some issues with.
Yeah. This is the one that I was nervous about. So that's
awesome. I just thought, did anybody check the is it the APDVS email?
Inbox?
Yeah, I've been monitoring it.
Nothing. Oh God, thanks. Yeah. I just thought of that. So okay.
Yep.
Good. So nothing in there either.
No, and nobody came in as an attendee. I was like looking at that attendee list, like, oh my God, it's but it was fine.
Yeah, we got everybody.
Great.
Good.
Cool.
Okay.
All righty then.
If nothing else, thanks, Pete, for everything.
No problem. Good to go for tomorrow. So
you guys shortly, I feel like.
Yeah, I know.
Well, I'll sleep 1 hour longer than you. All right.
Okay, guys.
Good night, everyone.
Have a good night.
See you later.
Thank you.
Bye.
Bye.
All right, Lynette.
We're always
Run
the
down.
last, right?
I know. I always stay on just in case there's anything else.
Thanks. Good job tonight. I think everything, was really
Yeah.
good.
I think it was all good. I was so nervous that people would come in as attendee, but no one did.
And then plus when we started so late, I mean, with that guy who needed help, I'm like, we need to open this because I think there's going to be problems getting people in.
I know.
So
I know.
that was.
I know. I know.
But it all worked out. So thank God.
It did. Perfect.
Okay. Enjoy the night.
Thanks. You too, Lynette. I'll see you tomorrow.
Okay. Bye-bye.
Bye.